So we are going to go ahead and start the next session. Next session is basically is on changing trends in coronary revascularization. So Dr. Tahir Sagir is here, so I'll just hand over to him. In the meantime, I'll just introduce I'll request the panelists to come up there. If they are here, Dr. Nadeem Kamar, Dr. Nadeem Hayat Malik, Dr. Usman Fahim, Dr. Feroz Mehman, Dr. Saqib Shafi, Dr. Noman Nasir, Dr. Shahbaz Qureshi, and Dr. Kamran Babar. Yeah, I think online we have Dr. Robert Payo is still there, Dr. Tariq Shahab, welcome again. Dr. Arshad Ali, I don't know if he's there. Dr. Professor Suong Won Ra from Korea, Dr. Naeem Tahir Kheli, and Dr. Muhammad Hafizullah, I don't know if he is there, he is sitting in the US, he was supposed to come online, and Dr. Rosalie is there too. So thank you very much all the panelists on line as well as I guess physically we have currently one person there. So if I could request General Suhail Aziz, Dr. Nouri, if you could come up to the stage also please. I'll appreciate it. And Dr. Tariq Abbas. Okay, Dr. Tahir Sagir, please go ahead.
Thank you. This session is about the changing trends in coronary revascularization. I would now like to invite Dr. Anjum Rana to present his case and talk about the patients in CKD with low contrast PCI.
Bismillahirrahmanirrahim. Thank you, Dr. Tahir Sagir. Okay, I would like to share this case. In this case, we did not have a challenging anatomy, but the clinical scenario that was challenging, which was the deranged renal function in this case. Okay, a middle-aged man, hypertensive and smoker, presented with non-ST elevation MI. His echo showed a preserved EF. Grace was 115, but the bad thing was his creatinine was, hovering around 4.0, 4.1, 4.2, something like that, while 2 days of his admission inside the hospital. After conservative initial medical management, still he was having symptoms. So in 10 to 12 ml of contrast, his angio was already done. And I would like to show you the images. As you can see, there was a tight or subtotal stenosis of the left diagonal, large size diagonal 1, and there was a stenosis in the LAD as well at the bifurcation point. So the case was discussed in heart team. PCI was opted as a first option, and we have an in-house nephrologist, and with his opinion, the problem was with giving contrast. So over here, after heart team discussion and discussion with the family and the nephrologist, the interventional cardiologist himself planned for an option of going with ultra-low contrast or zero contrast. So target here was to doing a zero contrast PCI in this case. The left circumflex, as you can see, and the right coronary artery, they were normal. So IVUS guidance was basically selected for this case, and the contrast fringe was not attached to the manifold in this case. After engagement of the guide, you can see we saved all the views. This is the fluoro-guided contrastless wire placement of the BM into the LAD, followed by placement of another wire into the diagonal. That took some effort. There was a propensity to give contrast, but it was done under fluoro guidance. After that, the diagonal was dilated with a 2.5 NC balloon, 2.75 NC balloon at 12 to 14 ATM, followed by IVUS of that diagonal after intracoronary nitrates to assess the distal proximal landing zones, the disease site, the reference vessel diameter and to select the stent size. The reference vessel diameter you can see over here was 3.2 and the length was 21, estimated length from here to here. So a 3.30 into 24 stent was selected for the diagonal. The IVUS of the LED was also done, and you can see the reference vessel was diameter was 3.4 and length was 35. So a 38 millimeter length was selected for the LED. And this is the ostium of the diagonal over here before the stent. So based on the IVUS, a 3O balloon was kept into the LED and 3O stent was taken into the diagonal because we were planning an upfront 2-stent bifurcation strategy. But the $1 million question over here was which strategy to go for, because the ideal strategy for 2-stent in this case appeared to be a standard decay crush, so which has been shown by multiple studies. But you know, to place this stent of the diagonal precisely at the ostium, this is the time when multiple views are done in epicranial, allocranial, multiple angulations, and involves a lot of contrast. So how to position the struts at the ostium of the diagonal without giving a lot of contrast? So for doing that, so any ideas or any thoughts from the hall? We selected the nano crush for that, because in nano crush, you have the liberty that entire of the lumen of the LED at the bifurcation point that is occupied by the balloon which is inflated over here. And after inflating this balloon at a nominal pressure, you pull and make the shaft of this diagonal stent very taut so that it can make an indentation into the semi-inflated balloon in the LED. And by doing that, you are pretty sure that only one strut or less than that is hanging into the LED. And you do not need to give a contrast moreover for that. So by doing that, this 3O balloon was inflated in the LED and the stent was inflated in the diagonal, followed by the first case. The diagonal, both the balloons were pulled a little bit proximal into the LED. The diagonal stent balloon was inflated at higher pressure to do the adequate apposition of the stent, followed by the first case. So there was a propensity to give the contrast over here, but the contrast range was not attached. And IVUS was used here to analyze this stent deployment. So IVUS told us the distal edge, the proximal edge, and deployment of the stent, and the stent was a little bit underexpanded, so a 3.25 NC at 14 to 16 ATM was done, followed by re-IVUS, and which shows an adequate MLA of 8.2 well-opposed stent and no dissection in the distal or the proximal part. This was followed by, the rest of procedure was a little bit more simple. This was followed by placement of a 3.5 38 stent into the LED, as you can see, followed by part with the 3.5 at 16 to 18 ATM, and this is again the fluoro. You can see the recrossing was done with the new BM from the mid strut, in this case, which is the ideal, followed by dilatation of the side branch struts, and the second case with 2 NC balloons, and a report with 3.5 NC balloon. Now, should we give a cine or not? So still, the syringe was not attached, and to assess the LED stent deployment, IVUS was done again. So the point of interest for the IVUS was the entire of the stent length, the area proximal to this stent and distal to the stent as well for any edge dissection or residual plaque burden. So the IVUS showed excellent stent deployment. After dot and pod, the MLA was 11.1 millimeter square for the LED, is pretty excellent. There was no complication like edge dissection or something. So all of this procedure was completed without any single shot of contrast and only doing IVUS guidance. But at this point we could not resist, and we had to use 2 to 3 ml of contrast to do one single shot to save it for the record, and we were able to show it over here as well, as you can see. The creatinine next day was again around 4, and the patient is in follow with the nephrologist, and he is following us as well. There's a bit of bridging in the mid LED, as you can see. So during entire of the procedure, usually we think, and in our mind is only the coronaries and the heart. So this is how our cerebral hemispheres kept on looking on the background of a 4-point something creatinine. Thank you. So there, I am unable to show the literature. Unluckily over here, there are case reports on that, and it's a quite effective technique to do the bifurcation until unless one of the vessel is totally occluded. Thank you.
A comment, if you may, Dr. Anjum, very well done. But I didn't see, I'm not sure if there was any hint there of prehydration. That's one of the most, effective way of reducing the chance of contrasting nephropathy. Other is that, if you take the GFR and you multiply it by 4, that's the amount of dye you can do without damaging the kidney. So let's say the GFR was 10, you could still give about 30-40 cc of dye. And in the end, you really have to give an injection despite using an IVUS and all those things, because if there's a dissection somewhere or something, you need to know. And another way of reducing dye contrast is to use a little larger diameter of guida and put in a micro and give check with those micros, which can just take maybe less than a cc, half a cc, and you can see exactly where you are. So this is a great way, and we must know all these different ways of doing it. Very commendable, but certain things like hydration and microcatheter injections and those things need to be taken. And if you haven't prepared the patient, then soda bicarb infusion is very effective. Otherwise, you have to hydrate.
So excellent comments, thank you. Because the nephrologist was also along with us, he was getting regular hydration, although we did not use soda bicarb in this case. So thank you.
I think that that was an excellent case with almost or near zero contrast, but we've done quite a few cases where the creatinine has been hovering around 2, 3, or 4 milligrams, particularly in diabetics, and as Sohail Aziz pointed out, after hydrating them, giving them soda bicarb, we've used 3 different techniques, 2 fairly commonly. One of them is diluting the dye. So if you take 5 cc's of the dye or 3 cc's of a dye, 100%, which is neat, dilute it up to 10, that means 1/3.
1/3 of that.
Of that.
Yes.
And if you inject it, you get a fair amount of good idea, provided you have reviewed your diagnostic coronary angiogram, and you can do with minimal dye, with less than 5 cc's of dye, you can do your angioplasty.
Yeah, that's an excellent way to
That is one technique,
minimize.
and to check whether the opacification is good enough, you take three syringes, one with 10 cc's of dye, one with 1:1 with normal saline and dye, and one you take 2 parts of normal saline and 1 part of dye. You find between the first and the second, there is hardly any difference. There is some reduction in opacification in the third, that is 1/3. And that gives us fairly good idea of post-angioplasty results. The second is using the roadmap. For example, you have a right coronary artery where you have a mid disease and renal functions are impaired. Then the diagnostic coronary angiogram, you see that, do a roadmap, come back to the same views exactly while the heart is beating, take a little longer stent. So instead of taking an 18 millimeter stent long, take about 23 millimeters. So that again, you can get over this and you can deploy it. The third, which has been seldom used, but we have used that, we know that the contrast, when given into the coronary arteries, finally drains through the coronary sinus. So you have one catheter placed in the coronary sinus that is going to the right heart, and then injecting the dye after 2 or 3 seconds, you drain the blood from the coronary sinus, see it behind the fluoroscopic screen, and you find the contrast there. And that is another way where you drain the dye, where you have to use a little larger quantity of the dye. You drain it before it actually goes down into the kidneys. So these are the 3 other techniques which we have used. I wouldn't say very frequently, but every now and then we use these 3 techniques.
Thank you. Thank you. So unluckily, my supervisor who was standing next to me, he didn't give me any dye in this case. So the dye was not there. Just a comment. But actually, in this case, all the measures you have given, they are extremely, extremely helpful and useful, and they can be used routinely in a lot of cases, especially as Sir Sohail mentioned, injecting through the microcatheter. It's a very useful technique for doing the CTOs. So they are all the excellent techniques for ultra-low contrast. Actually, in this case, my supervisor planned or advised me to do a zero contrast. So that was one of the reasons that I had no option to do any contrast at all, except if there is something not for the patient is not safe, and we did only one view at the end. Thank you.
Thank you. Thank you. Excellent work done by Rana Saab.